I want to thank the organizers for inviting me to be here today. It's a little easier to talk about the technique of graft nephrectomy, so if you like, I'll start that. But no, let me get into some of the issues with organ allocation. I've been involved with UNOS for about 15 to 18 years now, and this comes up just about every single meeting, and it will for a long time. So no disclosures. So really, allocation of any of the solid organs is really how to please none of the people none of the time, right? Because what we realize is that it's rationing. You all know better than I, way more than 100,000 candidates and even more not referred. We do about 13,000 to 14,000 deceased donor transplants, another 6,500 to 7,500 living donors, getting us in the 20 to 22,000 range. We discard between 3,000 and 4,000 a year. That means organs that are procured that possibly may be transplanted and are not transplanted. And again, there's just far more of a need than a supply. Everyone has to show this graph or you use your transplant union card. So the number of people on the wait list keep skyrocketing, the number of transplants increase slowly, and unfortunately the number of discards are also increasing. Discards is complex. I'm actually going to be talking a little bit later. And discards also depends on what aggressively you procure. So a problem that needs to be addressed. The real reason, obviously, you refer patients for transplant isn't just to have an increased quality of life, but it's also because people live longer. And I was just blessed to give some of the pediatric discussions from Dr. Ferris, and for especially the younger patients amongst us live multiple decades longer with a transplant than on dialysis. But even us folks who are getting older and those of official retirement age live about twice as long with a well-functioning transplant as on dialysis. So it increases theoretically not just quality of life, but also how long you will live. So some common themes both with kidney allocation / transplantation as well as other solid organs, because this discussion has not been having an isolation on just kidney, but all solid organs, and it's very much intertwined right now over the last 2 years. So some things that we discuss, number one is an objective measure of illness. So as those of you who are involved with some of the liver patients, and I always joke that when we have a sick liver patient dying in the ICU, the only two services at the bedside are the transplant surgeons and the nephrologist, right? So a measure of how sick these people are is, quote, the MELD score, the model for end-stage liver disease, and this basically predicts when someone would die. Thanks to the new allocation system in December of 2014, your kidney patients now go back to the time they started dialysis as an objective measure of, quote, their exposure to the disease process. Prior to that, those of you who were involved may remember that even if someone was on dialysis for 5 years, if they were just listed at the transplant center today, their wait time was 1 day. Now it'll go back to 5 years. It's still a big advantage to refer your patients before transplant when their GFRs are in the low 20, because they can get their wait time clock started when their GFR hits 20. And for many of our patients, they can actually get a preemptive transplant, not just living donor, even theoretically deceased donors, as we care for these patients in a much better way, especially our PKD patients. Now, the LAS, or the lung allocation score, is very interesting. It's extremely complex. You need to have at least your master's, if not PhD, in math to understand the formula. It looks not just on how sick are you and do you need your lung faster so you don't die. It also gives you some priority estimating your outcome from the transplant. So that's also been one of the holy grails, and that's what's the benefit from transplant. So should we be looking at allocation of organs on who's going to get the most out of it, whatever that means? And the lung system actually already does that. The big problem with this is you can estimate this in larger groups of people, so people with diabetes, people with some certain disease process. Obviously not that accurate on an individual person basis, which has always been the argument against this. And really, what you asked me to talk about today is, quote, fairness to access, allocation, and in the US right now, that's coming down to the concept of geography, which I'll go into. So there are 58 different organ procurement organizations, which are also called donor service areas in the country, and they pretty much each have different deceased donor organ donation rates. And I'm going to talk really only about deceased donor kidney transplantation and other organ transplantation today. And here's a little map that you can find online. Also, as you know, transplant centers will waitlist different candidates. They may waitlist a certain degree of illness, and/or they may be in a part of the country, such as a southeast stroke belt and hypertensive belt, where a larger prevalence of their population has end-stage renal disease. You folks know this better than I. And in fact, they may also affect the percentage of the population that are acceptable donors. So this yin and yang between the availability, the supply, and demand results in drastically different transplant rates around the country. Some of it is also gameable depending on who you list or not. To go back to some history, kidney sharing or allocation actually started with a group of docs before it started with the federal government. So COP, or the Southeast Organ Procurement Foundation, started what we call UNOS, the United Network for Organ Sharing, which is a private non-for-profit company. And what happened is that transplant surgeons and physicians in the Southeast were looking at deceased donor transplantation back in the 70s, when I was still in high school, and deceased donor transplantation outcomes were terrible. We knew that when we had well-matched siblings with the medications we had, which are pretty much azathioprine and prednisone, we can get away with some of those, but when you had poorly matched deceased donor candidates, things were abysmal. So these 8 centers got together and said, why don't we try to tissue match a little bit more? And this is where that whole concept of matching comes into now, right? Patients always come and say, they told me I had a perfect match. We all know the only perfect match is an identical twin. There's a couple of them in the world, but most people don't have identical twins. But in these days, people realized our medicines are so poor, we only have azathioprine and pred, this was even before cyclosporin, that we need to give our patients a better outcome. These patients are good and healthy, but we give them organs, you know, we stop the high-dose steroids, put them on pills, and half of them blow out their graft, and some of them died from severe acute rejections. So they got together and said, you know what, let's share, we want this to work. So this was biological allocation. And at the time, they could find high levels of antibodies with the old complement-dependent cytotoxicity cross-matches, but not low levels of antibodies. And they did know a bit about tissue typing, not as much as we know, but they were following A, B, and DR alleles. You know, you get 3 from mom, 3 from dad, so there's 6. They gave each one 2 points, and basically you get up to 12 points if you matched a donor. So again, biological allocation. If there was a tie, we'll give you a point a year for waiting. You weren't going to wait that long, those years on dialysis, only because the survival wasn't as good. So this is how allocation occurred. They published this after 1 or 2 years of sharing, and everyone else in the country pretty much wanted to voluntarily join. So they started adding adjacent state by adjacent state to allow this to work. And this is just about the time that it was being discussed within 5 or 6 years by the federal government, where we need to oversee some of this deceased donor transplantation events. Cyclosporin came out in the early 80s, and then guess what? Transplant actually worked now. And not just kidney transplant, but extrarenal transplant exploded. Now the demand far reached the supply, and things needed to be done. The federal government got involved. NOTA, or the National Organ Transplant Act, came into play. This creates actually 2 contracts, the Organ Procurement Transplant Network and the Scientific Registry. UNOS as a private company split off from COF and got the first contract for both of these, still runs the clinical arm of this. And our first transplant outcomes were published in 1992. That's a long time ago. So the 1991 outcomes were published in 1992, and people would argue that's the end of a lot of things that occur in transplant, but we'll talk about that on the next lecture. And this is the current kidney allocation scheme as it applies today. What you'll notice is besides sharing for some super highly sensitized people, we still get priority for, quote, local patients over regional patients over national. And this is where the organ procurement agencies have been able to go ahead and have those organs procured, and then where are the transplant centers relative, which ones are aligned with that OPO. Here are the 58 different organ procurement agencies, which then create a donor service area. Most of them came up because in the day, if you were a transplant center, you had to go get your own deceased organs. So you started up your own organ procurement agency, or OPO. As new centers came in, they joined existing OPOs. Some centers still have only one OPO in one center. Other places, there's a dozen, or even in Philadelphia, 17 to 18 kidney programs off of one OPO. So it's vastly different around the country, and this is really the major difference for the time to transplant around the country. For administrative reasons, UNOS went ahead and organized these DSAs into regions, and there's 11 regions. We still use these for our meetings. So if you go to a UNOS transplant meeting, I'm in Region 3, I'm gonna go to Atlanta because that's where all the planes fly in and out of, and we're gonna have our meeting twice a year. So every 6 months we have a big meeting. UNOS also used this as the next level of allocation. So it went from your local OPO area to your region and then to national. So again, it kind of came out of just the system that was developed. There were the liver wars in the mid-90s, for those of you who remember, from about 95 to 2000, where states were saying, I'm going to keep my liver in my state and I'm going to go to court and we're not going to share anymore. So Donna Shalala was the HHS secretary and came out with this clarification of NOTA, known as the Final Rule on Transplantation. And basically it says the policies for equitable allocation of deceased donor organs need to follow the following rules. And this is like truth, justice, and the American way, right? Sound medical judgment, best use of donated organs. A patient or a center may decline an organ and not be thrown off the list, okay? We need to go ahead and have different rules for different organs because the patients aren't the same if you need a kidney or a liver or a heart or a lung. Avoid wasting organs, avoid futile transplants, because you could argue the sickest patient is the one who's dying this second having CPR. Doesn't make sense to put an organ into them, right, no matter who they are. Promote patient access and promote the efficient management of organ placement. That's a loaded one, number 5. Needs to be reviewed, transplant centers need to follow the rule. And then number 8, shall not be based on a candidate's place of residence, that is geography, unless it interferes with 1 to 5 above. So that's the whole summary of the geography argument. I can go sit down now. So those who want to share more say number 8 rules, and those who don't want to share too much say, but it's going to increase wastage and futile transplants and decrease outcomes. Okay, so that's really the legal precedence of all these arguments. People were having similar arguments now in the last decade, 2015 to 2019. In fact, people were saying, and this started with liver again, MELD is a good predictor of who's going to die if they don't get their liver transplant. Therefore, we all need to share nationally, and the sickest patient gets the next organ. But others came out and said, not so fast. MELD isn't quite that accurate. And in fact, depending on where you are in the country, your socioeconomic status and your access to health care has a major role to play on when you're going to die, independent of your MELD score. So if you live in LA or New York, you may die with your MELD score over 35. If you live in rural areas of South Carolina, you may die with your MELD score at 22. Lots of publications, you can look them up. And the HHS director at the time came up and said, well, wait a second. We know we have to address these inequalities because of socioeconomic statuses. We're not sure exactly what we can do with this. You can take it into account, but what we're doing with those funny measurements of the DSAs in the regions, no matter what you say, that just doesn't fly. So you can change this and you can take the socioeconomic inequalities into account, but you still can't have those funny drawn boundaries. And a big argument, for example, if you're in New York, you could be waiting half the time than if you live across the bridge in New Jersey for an organ transplant, all right? So what's come up in the last 2 years, actually, heart switched pretty much first to allocation zones. So instead of local, regional, national, zone A is 500 nautical miles, not land miles. And a nautical mile, 500 nautical miles is 575 land miles. That's something I learned throughout all this. Second zone is 1,000 miles. Lung is actually just switching from a local first, then a zone A, zone B, to no local, with zone A at 250 miles and zone B at 500 miles. So you can see, because of the different organs, the circles don't need to be the same size. Now, liver's been a hot topic for a couple of years now, and you know it's in the newspaper, it's on the news, because there's a lot of actual legal challenges to some of these changes. Currently, if you're a, quote, status 1, which is acute liver disease without prior liver disease, unless you have acute on chronic Wilson's, Or if your MELD score is 35 or higher, and most of those people are the ones you know, they're in the ICU on CVV HD, right? Their blood pressures are 90 on pressors. They have bilirubins of 40, you know all these folks. Those are regional shares first. So that's where we go past local to regional, because it is these people are sick and they're going to die. In fact, if you have a high MELD score over 35, you have a higher risk of dying than if you're a traditional status 1 patient, because usually status 1 patients were otherwise well and got acutely ill. So they usually have one broken part, as opposed to the chronic liver disease patients who, as you know, have multiple broken parts, including their kidneys. Then when you're less ill, your MELD's under 34, it goes back to local, regional, national. That's in play today. New policy approved by the board a year ago, 13 months ago, was the switch to circles, and for the sickest patients, 500 nautical miles circle, and then going by various groupings of MELD scores. The sickest 37 to 40, then 33 to 36 would be concentric circles. So if you're real sick, smaller circle, 150, then a 250 circle, then a 500 circle. So the idea of that was not to be crossing planes all night long in the middle of the night, because if you do this for 500 nautical miles, you're flying a couple of hours to get a liver for a MELD patient 40, and that center's flying to your center to take your donor for a MELD of 39. So the idea was have a little bit of cushion and don't fly every single plane in the whole world. We actually were theoretically running out of charter planes if we did this. The kidney policy is still this as of last year, and then in the middle of last year, it was discussed how we move from this local, regional, national to circles. So in October, the kidney committee came out with the proposal of let's look at 500 nautical mile circles, and we'll give, quote, 4 proximity points. And I have a cartoon to explain this. So that a patient will go up and down the list. Today, it's basically wait time plus your sensitization points for most of us, right? To this, we would add up to 4 proximity points, and the proximity was the donor hospital as the center of the circle, and the transplant center, how far away is the transplant center, okay? So with this cartoon, this is a 500 nautical mile cartoon. In this case, the donor center, the donor hospital in the middle is not a transplant center. If they were, those patients would get 4 points because they're 0 miles away. The first transplant center here, A, is probably 75-ish miles away, so it's going to get about 3.75 out of the 4 points added to all of the people on their wait list. And center B is a bit further away, they're going to get about 2 points. So you can see that the idea was to try to be efficient with how far you're traveling from the donor hospital. Most of these are not flown on charters, right? They're flown on commercial jets, as we know, or they're driven. So the closer you are, the more likely you can put them on a pump and drive them, and that was basically what the arguments were. This was some of the data that the Kidney Committee through the SRTR discussed. The top line is basically what happens now, and on the bottom, which I know you can't possibly read, are the 58 different OPOs or DSAs. And basically, this looks at, quote, transplant rates, which is a very gameable number, but basically the number of transplants you do over the number of people you have listed in your donor service area, low to the left, high to the right. And they said, well, if we make 250 or 500 nautical mile circles, we kind of make it a little bit more fair, not perfectly, but a little bit more fair. So they pushed out the 500 nautical mile one. We again discussed how far the transportation would be. We actually may lose some kidneys because some of them do get lost when they're transferring. You know, their legs are really small and they miss their connecting flights at times. So the community went back and said, hey, 250 does almost the same as 5. Why not go with 250? So guess what? They actually listened to public feedback and they changed the proposal to the board last month to 250 nautical miles with 2 proximity points, instead of 500 with 4. So again, the centers within 250 have a little less discrepancy between them. Outside of that, if the centers within that 250 circle do not want to accept the organ, it will then go, quote, nationally to a larger 2,500 nautical mile circle, starting with 4 points. Perfectly clear as mud, right? Basically 250 circle for all the good kidneys. They're not going to get out of 250 nautical miles, right? So that's what was approved. And it hopefully will be implemented by the computer system by December of 2020. So that's the next change that your patients are going to see in kidney allocation. You're going to go from local, regional, national to a 250 nautical mile circle. And here's some centers I was at. You can go online actually and play with these off the OPTN site and the UNOS site. On the left is actually UNC Chapel Hill as a donor center. The blue dots are 250 nautical miles, green are 500. On the right is where I'm in Gainesville. You can see there's not much around me but alligators. But 250 miles will go up into Alabama, Georgia, and even into South Carolina. So if we were the donor hospital, any transplant center within those circles would be up first for the organs that come out of our center. Does that make sense? Here we are in LA on the left, that's UCLA. And on the right is my hometown, Philadelphia, that's Penn. So you can see it gets a little different whether you're where there's big states on the West Coast or where there's a bunch of smaller states on the East Coast. And the big issue here on the East Coast was, oh my, when we do this for not kidneys, for livers and things, how many planes are crossing in the middle of the night? All right. So the pros and the cons, and this is a great high school debate topic because you could take either side and go on for hours and hours, but I only have 8.5 minutes left. So on the left, people who don't want to share too widely say there are strong, important relationships between transplant centers and OPOs, and hopefully that increases donations. Those on the right say, a lot of studies say that people just want the sickest folks to get the organs. On the left, the more you travel, the more you will increase cold ischemic time, which equates to more delayed graft function, a little bit more primary non-function. You may have lower long-term graft survival, which is probably true, and we know this from some of the highly sensitized kidneys we fly around the country. But on the right, we already do this, not that big a deal in the short term at least. Unintended consequences are something we always worried about, and when we came out with the new kidney allocation system in 2014, we missed a couple. We weren't too bad, but we missed the huge amount of sharing you would do for the highly sensitized. And in fact, those with CPRAs of 100%, up to 99.95 are actually over-transplanted these days. That needs to be fixed a little bit. But basically, less efficiency of organ allocation is going to happen when you have larger circles. There's just no way around it. We're going to increase time, as I just talked about. We may have some decreased outcomes. We may have increased cost in the long term. Center with shorter wait times, right now, if you're near a center with longer wait times in another OPO, which is only a few miles away, you may see a dramatic decrease in your offers of deceased donors. So in North Central Florida, there's a center south of us who's estimating to get 1/3 of the number of deceased donor transplants for several years until their average wait time comes up to meet everyone else. So if you have a small, moderate program, are you going to put them out of business? So that's always a little bit of a concern. Transplant centers closest to the donor hospitals get an advantage. So where I am at UF, we have a sister hospital actually in Jacksonville that has most of the trauma donors. They're closer to a larger non-academic program than to us. So actually the larger program closer to them will have about a 0.7-year advantage over our patients on getting these organs. So again, nothing's perfect and there are things that come up. The bottom line is this is rationing. No one likes rationing unless you're getting more of the ration tickets than someone else. So I'm happy to entertain any questions. Or are we going to do that at the panel discussion? Panel discussion. I actually finished on time.